Now I'll try this again. Good afternoon, since it is now officially afternoon, and happy Halloween to everybody. I'm AJ Scheitler, the Director of Stakeholder Relations here at the UCLA Center for Health Policy Research, and today I have nothing but treats for you. Two big pieces of news as we come back from our summer hiatus and go back into our monthly webinar series. We have two back-to-back webinars this week and 1 week from today, Wednesday, November 7th. On November 7th, we're going to be discussing the proposed federal change to the public charge rule. With the comment period now open and open until December 10th, Dr. Inez Ponce will share current analysis of the effects of the proposal on California. Together with our partners, the UC Berkeley Labor Center and the California Food Policy Advocates, we will be sharing estimates of the health and economic impact for California and its local jurisdictions. And we will also preview a policy brief that we're going to be putting out in December. So that is next Wednesday at 10 a.m. I know that that's a little earlier than our usual noon time, but you all get an extra hour of sleep this weekend as the clocks fall back, so you'll be good and ready at 10 o'clock next Wednesday, November 7th, for the public charge webinar. Now, for today's treats. Today, we have new data from the California Health Interview Survey. Now, before you run off to the website to go check it out, we have Dr. Inez Ponce, the CHIS Principal Investigator, and Todd Hughes, the CHIS Director, to lead us through what's new and what's trending in the latest round of data. Today, Todd and Inez will also discuss a policy brief that's being released today in conjunction with the California Healthcare Foundation on what the latest CHIS data show us about health insurance trends here in California. As always, today's webinar will be archived on our website for viewing at any time. If you'd like a copy of the slides, you can reach out to our interim Communications Director, Vinitya Lay. Her email address should be on your screen right now. Also, if you are joining us online today, please feel free to use the chat function to fire off any questions that you have. And at the end of the presentation, we will take questions in the room and from those who are online. Now, let's get down to business by introducing today's speakers. Dr. Ponce is an expert in population health surveys, social determinants of health, and health disparities. She was here to help develop the original CHIS survey in 2001, and today she is the director of the Center of Health Policy Research here at UCLA. Before joining the center in 2016, Todd Hughes had a 20-year career at the U.S. Census, most recently as an assistant division chief for the American Community Survey. During his time there, he oversaw new efforts to increase response rates, including an internet response option, as well as changes in ACF mail methodology and adaptive design principles on follow-up methods. He is now bringing his experience and magic here to CHIS. And now I welcome Dr. Ponce to unveil what is new, what we've all been waiting for, CHIS 2017.
Thank you so much, AJ, and welcome to everybody here who's joining us in the room at the UCLA Center for Health Policy Research, and welcome to those of you who are joining us via web. So I was on the elevator today and I ran into Errol, who is one of our statisticians for CHIS, and he said this is the most exciting day of the year, and with his Halloween costume. I think it was not about the Halloween costume, but really about the data that we're going to preview and show today. So I agree with you, Errol. This is the most exciting day for us at the Center for Health Policy Research and the CHIS team. So this would not have happened without, first of all of the Californians who responded to our survey. So first we should thank the Californians who took the time to go over our questions and respond for themselves, and if they had a child or a teen, to respond for their child and allow their teen to respond for themselves. I wanted to thank the CHIS staff, thank you again, and their tireless effort over the past 10 months to get where we are today. And to get to where we are today was also made possible because of the leadership of Todd Hughes. So we're going to do some back and forth in the presentation, but I want you to welcome Todd Hughes to get us all started.
Thank you, Ninez. Hello, everyone. Welcome to today's seminar. I'm Todd Hughes, the director of the California Health Interview Survey, or CHIS, and I'm very pleased to share with you the public release of the rich information that we collected as part of the 2017 iteration of the California Health Interview Survey. If you're a little bit less familiar with the CHIS, I'd like to start with some broad background information for you. First, the CHIS is the nation's largest ongoing state health survey. It's a comprehensive source of health information on Californians that covers an extensive, diverse, and timely set of topics that are relevant to today's needs for information. This includes issues on health status, health conditions, and health behaviors, and to issues such as mental health and oral health, access to and utilization of healthcare, to employment and other social determinants of health, and certainly the extensive information regarding health insurance coverage for all Californians. The CHIS has something for everyone, and it's always evolving to reflect current information needs. The CHIS is truly an invaluable assessment tool for population health data, and it meets both state and local needs, whether that be for policy analysis and advocacy, service and program planning, or many other custom research needs across our diverse state and across the country. The CHIS is a valuable resource, and many organizations have demonstrated the value of the CHIS through their financial support of the survey and their collaboration with us in conducting the survey each year. This includes both federal and state government agencies, as well as California and national foundations, and many other groups. So I would like to pause for a moment here and thank again all of these organizations for their ongoing support of the California Health Interview Survey. The design of the CHIS provides for estimates for the state of California as a whole, as well as many other population groups, and this can include smaller levels of geography, including most counties, as well as cities with health departments. We also produce estimates for all of California's major racial and ethnic groups and some smaller ethnic groups as well. Additionally, it's been a key mission of the CHIS to share information from the survey as broadly as possible and to as diverse a set of audiences and data users as possible as well. So I'd like to describe a little bit about how we conduct the survey. The survey is currently conducted by telephone, and CHIS telephone interviewers work to collect information about 3 different age groups using modified questionnaires for each one. First, we'll interview one adult, age 18 plus, in the household. If that adult is the parent of children living in the household, then we will also ask that adult questions about one child, age 11 years old and younger. And additionally, we would ask their permission to interview one teen, age 12 to 17, if one exists in the household. To better reflect the diversity of California's population, we also provide language assistance in several different languages, including English, Spanish, Chinese, both in Cantonese and Mandarin dialects, Korean, Vietnamese, and Tagalog. And if you're interested in seeing those translated versions of the questionnaire, they're available on our website at the link presented on this slide. The table on this slide provides information on how many interviews we conducted by age group and by race and ethnicity. As you'll see, we conducted over 21,000 adult interviews, over 400 adolescent or teen interviews, and we conducted interviews in regards to 1,600 children aged 0 to 11. Because of California's diversity, CHIS is relied upon for its wealth of data on many racial, ethnic, and gender minority groups. And counts of interviews in 2017 by each racial and ethnic group are displayed here on the slide. And the CHIS relies upon multiple different sampling strategies to ensure that we can effectively represent each of these groups to the extent that's possible. But enough about how the CHIS is conducted. I know you're as anxious as I am to see some of the survey results, and we're excited to have Dr. Inez Ponce come back to the podium for a discussion of some key interesting findings from the 2017 iteration of the survey. Inez?
Thanks, Todd. So I wanted to let the audience know that we just issued an issue brief with California Healthcare Foundation. The header is ACA Reduces Racial Ethnic Disparities in Health Coverage. and that's by Tara Becker, one of our researchers here. The CHIS data also informs ACA 411, which is a California Healthcare Foundation a tool that helps track the progress, the gains for the population of California before and after the ACA. And for many more publications, please visit us at healthpolicy.ucla.edu. Okay, so let's start with coverage. This slide shows coverage since 2011 to 2017. I think the key line to look at is this blue line, which is the uninsured rate. And it covers the uninsured rate in 2011 was about 16.2%, and in 2017 at 8.5%. We see the decline happen right after the rollout, or about the rollout of the ACA for the Medicaid expansion, as well as the Covered California introduction. And we, pardon me, I think this is going to advanced. And we see that the big source of coverage gains were from Medi-Cal. The Medi-Cal increased from 2013 to 2016, and we start to see a decline in the from 2016 to 2017. But with that decline, we're also seeing an uptick of employer-sponsored insurance, which is this orange line. And this new line up here, for those of you who track us each year, we have now a new line where we combine employer-sponsored insurance with the individual market private purchase. And that line is this purple line here. So the 7.5% plus the 51.2% would make the 58.7%. So overall, the story is that coverage gains are stable. They are still at an all-time low of 8.5%. That a lot is still driven by expansion of public coverage, but that we start to see this uptick in private insurance. When we look at the gains of coverage by race ethnicity, and we focus on Californians aged 0 to 64, this is because a lot of the ACA expansions affected the market that affected the 0 to 64 population and not the Medicare population. So for this group, again comparing from 2011 to 2017, we see here from actually to 2013 to 2017, we see that that the uninsured rates were high for Latinos, 21.4% in 2013, and down to 12.4% in 2017. We see that same pattern across racial ethnic groups. I think the key takeaway here is that if you compare the coverage rates or the uninsured rates of whites, African Americans, and Asian Pacific Islanders, that they're statistically about the same. So that post-ACA, or post the rollout of the ACA, we're seeing a convergence of those coverage rates and a narrowing, if not an elimination, of those disparities. However, for Latinos, despite the dramatic decline of uninsured rates from 21.4 to 12.4%, that Latinos still have higher uninsured rates than all other racial ethnic groups. In comparing what the uninsured rates are by region, in this slide, there's 58 counties in California, but we aggregate these counties into larger regions. And again, just focusing on the black lines to 2013 to the 2017 rates, again, declines across the board, across the different regions. we do see the steepest decline in the San Joaquin Valley region, from 18.1 to 7.6%. We see that the lowest levels of uninsured rates across the different regions in California is in the Sacramento area at 5.7%. We also see some coverage gains in Northern Sierra region, where the uninsured rates also declined dramatically from 16.9 in 2013 to about 8.2% in 2017. By income, for the top panel, which are Californians who have incomes from 0 to 138% federal poverty guidelines, the decline is the most dramatic in uninsured rates, from 23.2 to 10.5%. And we see a gradient in those declines, meaning that the gains are bigger in coverage for the lower income groups compared to the higher income groups. So that's our report card on coverage, and again, we have a fact sheet that is available today that was issued by the California Healthcare Foundation. Let's talk about some other indicators where we're looking at what happened in 16 and 17. So in 16 and 17, one of the indicators that surprised us and that concerned us was an increase in some of the mental health need and illness reported by Californians between 16 and 17. So among all adults that are 18 and older, there was a significant increase in reporting psychological distress in the past year, from 8% to 10%. A significant increase in the needed help for emotional, mental, or alcohol drug problem in the last year, from 16.4 to 18.5%. We see some increase and saw a healthcare provider for emotional, mental, or alcohol problem the past year, but not a significant increase. And ever seriously thought of committing suicide, a significant increase from 9.3 to 11.6%. These changes, these increases, are actually even more dramatic for the young adult population, for those adults age 18 to 24, where we see for likely had a psychological distress in the last year go from 14.2 to 21.1%, needed help for emotional, mental, or alcohol drug problem the last year from 22.4 to 30%, and saw any healthcare provider for emotional, mental, or alcohol drug use problem in the last year. Again, an increase, 14.8 to 21.6%. And an uptick in ever seriously thought committing suicide, but not statistically different. However, for the three indicators on mental health and mental health use that we track between 16 and 17, we see this alarming, statistically significant increase. Okay, let's talk about marijuana. So we don't have 16, 17 tracking, so this is one of the first times that we've had the marijuana sets of questions for 2017. And this is by age group, so this is to show what the percentage of adults in California who have ever tried marijuana. We don't distinguish between medical and recreational. This is ever tried marijuana. And we see that the mode, or the highest proportion, are among adults 25 to 34, close to 60%, and the lowest proportion among teens from 12 to 17. Looking at region, although we see a range from 45% to about 67%, they're fairly even across the different regions. although we do see some statistical difference between the northern and Sierra regions, which is the highest at 66.8%, and the lowest, which is San Joaquin Valley, as well as Los Angeles. By race ethnicity, among adults reported that they have ever tried marijuana. Again, we see some differences across race ethnicity. There might be some statistical difference between Hispanic, which is a fairly low proportion at 42.9% compared to a higher proportion among whites, American Indians, Alaska Natives, and those who report two or more races. The Native Hawaiian Pacific Islander category has a wide confidence interval, mostly because it's a very small sample. Okay, let's pivot to sleep. I'm just gonna I can't stop myself. How many here in the room slept 8 hours or more last night? Okay, we have one person. So it may be because your parents had rules at home, or you're in a household where there are rules. So in asking about hours slept on weeknights for California teens aged 12 to 17, that when there are rules present in the home in turning off or putting away electronics, that the mean number of hours are higher than on average than if a teen is in a household where there are no rules in place. And this is of really emerging importance in terms of health for not just for teens, but actually for everybody, all of you here in the room and all of you out there. So we have started tracking sleep in CHIS in 2017. Voting is next week, so I just want to remind everybody. And what else is new in CHIS is a measure on voting behavior, and a lot because what CHIS does is we are an omnibus health survey, but we do try to uncover the factors that explain why there may be differences in health and health utilization and health access. And a lot of that are, could be where you live, the opportunities that you see, the civic engagement that you might be encouraged to do in your communities. And a lot of this, have been associated to access to healthcare and even health. So in this case, registered voters. So this is among registered voters who report voting infrequently. In CHIS, our questions are on not just the presidential election, but also the presidential, the state, and local. And so based on responses to that, we created a construct on whether you're an always voter, frequent voter, or an infrequent voter. And this is our infrequent voting by region. Infrequent voting by region ranges from 30.7% to about 43%. By race ethnicity, infrequent voting again ranges from 33% to over 50%. And again, I caution you with the wide confidence interval for the Native Hawaiian Pacific Islander category. So with that, I think I'm going to call Todd Beth to talk about what's new CHIS.
Thank you, Ninez. I'm sure all of you found these results very interesting, and I'm happy to inform you that there is a wealth of other interesting information available to you from the 2017 CHIS that's ready for you to explore, which we unfortunately could not highlight in today's seminar. So we'll talk a little bit about what else you might see. As I mentioned earlier, CHIS evolves from year to year and from cycle to cycle to better reflect current information needs. And the next few slides provide a glimpse of what was new in the 2017 iteration of the survey. Many new topics were added to the adult questionnaire. They're shown on this slide. This includes questions related to marijuana use, including additional questions beyond those that Ninez highlighted the data for today. Additional questions about female pregnancy plans and male birth control, And beyond the voter behavior questions that Nina has highlighted, additional questions on voting registration and reasons for not registering are also collected and available. We also added questions on WIC enrollment, participation, and satisfaction, misuse of prescription painkillers and heroin use, and knowledge of and use of pre-exposure prophylaxis. So given that these different topics and different questions have differing levels of sensitivity and risk of identifying individual respondents, we put into place different levels of protection for different topics. And as you can see, there are footnotes for each of these that highlight the method by which that data for that topic is released, whether that be through our public use file, on our Ask CHIS dissemination platform, or through our confidential data access center. Additionally, there were some questions that were in previous iterations of the CHIS that were reinstated for 2017 after a period of absence. These include questions on smoking cessation, medical debt, usage of health savings account, and others shown here. There were new questions added to the teen questionnaire. We're very excited to share the sleep and technology use data that Nina was referring to earlier. Additionally, similar questions to the adults on marijuana use, frequency, and methods of use was also collected in 2017, as well as questions on birth control use and counseling. There were a number of questions that had previously been on the child questionnaire that were also reinstated for 2017, including prescription medication and therapy, developmental concerns, and usage of public dental health programs. Now, if you'd like to learn more about specific methodological changes that were in place for the 2017 CHIS, we encourage you to go to our website. That's listed at the bottom of this slide. You'll find this document, What's New and Notable in CHIS 2017, as well as a number of very detailed methodology reports that describe both our sampling strategies, our weighting methodology, and other details about how we conduct the survey. So next, I'd like to share with you a little bit about how this data is available to you all. It is a rich resource, and it's rich when it's taken advantage of. So it's our goal and our mission to be able to disseminate the data to the survey broadly. But as we do that, we have a few key aims that we keep in mind. First and foremost is the protection of the respondents' data that they give us, preserving the confidentiality of the information that they provide. And we take that responsibility very seriously. Next is to democratize access to the data, to make it available as widely and broadly across skill sets, across access type and need. And we do that through, and we try to reach a very large and diverse audience, different skill levels for technology, different statistical abilities, different research needs. And we've done that through a diverse strategy that's shown on the slide here. First, for the most skilled and savvy data users, we have our Data Access Center, which allows us to share information tabulated from the secure confidential data files in a manner that protects their confidentiality. Additionally, we have a public use file that was also released today that you can download for yourself, which is protected with various levels of anonymity to preserve the confidentiality of the data. And it's available in multiple file formats for you to be able to process the data and do your own tabulations if interested. But for a wide variety of users, Ask CHIS is a phenomenal resource that I encourage you to visit. It is our online health data query tool. It is live today with all of our new 2017 data. It's the recipient of a Health Data All-Star Award from 2017, and it's a very intuitive and user-friendly means for you to be able to examine different characteristics, cross it by other characteristics, filter it by geography and population group, and I encourage you to dive in. Additionally, we as a program have other tools. The Ask CHIS Neighborhood Edition and Ask CHIS NE en Español are two other tools for producing data estimates and sharing estimates at low levels of geography, as well as health profiles, which are easy to download, static tools or online profiles where you can see snapshots of key characteristics. And throughout all, we have a health data training program that can provide additional information on how to use the data and to build your capacity in data use. As we consider Ask CHIS versus Ask CHIS Neighborhood Edition, I want to highlight some of the differences in geographies. So the Ask CHIS system, which has been updated today with 2017 data, includes estimates for the state, at the state level, and for various counties, as well as for various population groups within the state and those counties. AskCHIS Neighborhood Edition uses model-based estimation to produce estimates for lower levels of geography, including Assembly, Senate, and congressional districts, cities, and zip code tabulation areas or zip codes. The AskCHIS Neighborhood Edition system requires that we have 2 years from a current cycle to be able to update the data, so that will not be updated until after the 2018 data are collected and processed, unfortunately. If you need some experience in learning how to use these tools, we do have a fantastic on-demand learning center where multiple videos on a number of key topics for using the AskCHIS system and AskCHIS Neighborhood Edition are available 24/7. In as short a time as 5 minutes, you can learn some great skills for how to do basic queries, how to display data visually, how to export your data in a variety of different formats, and a little bit of Statistics 101, how to interpret confidence intervals, pooling, statistical stability, etc. And so finally, I'd like to invite you to go now and explore the data at www.chis.ucla.edu. I would also like to thank our data collection partner for 2017, SSRS, as well as our content partner, PHI, and the members of our advisory board and committees, and especially the names that appear on this slide, who are the members of our UCLA Center for Health Policy Research CHIS team. I would bet all of them are here in the room. So I'm sorry you can't express your gratitude to them personally, but I certainly will. We thank them for everything that they did to make this data release possible. Thank you.
I think we're open for questions.
Okay, I'm going to start here in the room. Do we have any questions for our CHIS leadership in the room today? None. I will take the first question online. So you shared what's new in the survey. Is there a list someplace of what has been removed in this cycle?
What has been removed? We don't have as easily digestible of a product that will explain that to you. But if you compare the 2017 questionnaire to the 2016 questionnaire, which are both available online, you'll be able to make those determinations. Also, there's a list of topics, so that rather than diving through hundreds of pages of the questionnaire document, you can see which topics may have been removed from year to year.
Okay, any questions in the room?
Looks like they're conferring about the next online question.
No, we all just know it so well here at the center. Okay. So next question online. Are all the questions that you just talked about available in Ask CHIS? And the questioner specifically wanted to know about the birth control questions.
Okay. So if you go to the What's New document that I highlighted, or earlier, if you rewind the slide deck and you can see, oh, actually I can do that for you, can't I? So the current birth control use and pregnancy status questions with a footnote of 1 means that it's available in all of our CHIS data products. So the Ask CHIS system, yes, they're available in Ask CHIS. They're also available in the public use file. So you have either of those options for gaining access to those data.
Let me also try to clarify. I know that there was a question about the coverage slides. Most of what I was presenting are uninsured rates. So the title says health insurance coverage, but these are actually uninsured rates. And so it's the lack of coverage. So therefore, the 8.5% for the state, for the population age 0 to 64, is the uninsured rate. And then we probed more on the uninsured rate by different racial ethnic groups, by different regions.
Hey, any questions from the room? Moving back to online. When will the 2015-16 Ask CHIS Neighborhood Edition data be released?
That is an excellent question. It's certainly something we have been looking forward to being able to produce and release. It is still in progress. We hope to be able to do that in the first part of 2019.
Going back to the room, any questions? And there are no more questions online. So in record time, we have released the data. Everybody must be ferociously attacking Ask CHIS to look and see what the new data has to say. So
Hope you are.
Then we can
We have
wrap up
reports
for
that
today.
people have already
No.
used Ask CHIS this morning.
I was going to say this is so exciting to have such current trending data, and a lot of that is available on Ask CHIS. So I think we're just very excited to get going and really take a look at it. So congratulations to the team.
Thank you. And with that,
Thank you. Thank you very much.
Thank you. And with that, I just want to issue one final reminder. Next Wednesday, earlier time slot, 10 a.m. to 11, we will do an analysis of how the federal proposed rule change to the public charge rule will impact the health and economy here in California. So please come back and join us in a week. Thank you.